Mitral valve is like a door that opens gracefully when blood comes from left atrium to the left ventricle. But in mitral stenosis, there is stenosis of this valve. The literal meaning of stenosis is narrowing of the valve. So blood does not come normally from left atrium to the left ventricle. So introduction, it's saying calcification and stiffening of this mitral valve. This is left atrium, this is left ventricle, this is the left side of heart. So this valve is mitral valve, and when there is calcification and stiffening, calcification means it is a process in which calcium incorporate into this valve and slowly it becomes stiffened. Then it impede valve opening, mean the valve does not open normally and there is abnormal diastolic filling. Normally diastole happen, this left atrium contract and blood come to the left ventricle, but when this is contract, the blood does not come into the left ventricle. Now pathophysiology. So first, there would be chronic inflammation. The chronic inflammation due to any cause, like a patient is a chronic smoker or there is rheumatic heart disease. So chronic inflammation of this valve cause thickening, calcification and fusion of the leaflet. These are the leaflet, they become thickened, like its thickness is increased, calcification and fusion of the leaflet. These two leaflet fuse together. This would cause low mobility. Its mobility is less, like normally they are mobile. When blood come from left atrium to the left ventricle, they do like this one, hai na? They separate away and blood normally come, but now their mobility is decreased and its normal opening is also decreased. Okay, this would cause low left atrium to right ventricle blood flow. Normally the blood flow from left atrium to the left ventricle is reduced. This was called left atrial pressure increase and decrease cardiac output. How? Because when blood start to accumulate here, it's not coming here, so it will start putting pressure into the walls of left atria. So its pressure is increased and now there is less blood in left ventricle. Less blood will go out into the body. So cardiac output is also decreased. Now we'll study etiologies, like what are the causes of mitral stenosis? Why patient having mitral stenosis? The most common cause is rheumatic heart disease. What is normally pneumatic heart disease? In pneumatic heart disease, autoantibodies are produced. These autoantibody attack the body's own cell like of mostly the myosin of the heart muscle, but they can also attack this mitral valve. So it is the most common reason in developing countries like Latin America, Africa, Southeast Asia, like Pakistan, India, Nepal, etc. Now latency period is normally 10 to 40 years, means the first time patient was having rheumatic heart disease, suppose his age at that time is 10 years. So after almost 10 to 40 years, the patient will develop symptoms, like suppose his age become 35, at that time the appearance of the mitral stenosis will occur. It is short in endemic areas. Why? Because suppose a patient is living in Pakistan, so he is continuously exposed to that antigens, hai na? So its latency period is decreased and long in non-endemic areas. So second most common cause is radiation therapy. Suppose a patient is having cancer of Hodgkin lymphoma, so he goes to the chemotherapy and there is radiation treatment. Radiations fall on chest and these radiation can cause calcification and thickening fibrosis of this mitral valve. This can also lead to the mitral stenosis. So its latency period is normally 10 to 20 years. And the third cause is age-related mitral annular calcification. So what is mitral annular? This is mitral valve, this is leaflet, this is basically annular, this is leaflet, this is chordae tendineae, and this is papillary muscle. It is made up of 4 components. So this is annular, mitral annular. When patient age, suppose when age is more than 65 and is also smoker, hypertensive or maybe diabetic, these all causes calcification. The calcification could be in coronary arteries or either it could be in any blood vessel. So when this calcification occur in this valve, this can lead to the mitral stenosis. So 3 most common causes. The most common cause in developing countries is rheumatic heart disease, radiation therapy, and age-related annular calcification. Now pathology. Pathology could be of two types. Either it could be histopathology or gross pathology. So on histopathology, you will see the wall is thickened. Normally suppose wall are like this. Now they are thickened like this one, है ना? The wall could be thickened, calcified. There would be calcium in this wall or fibrosis. And in case of rheumatic mitral stenosis, the mitral stenosis that is due to this cause, rheumatic heart disease, in that there would be wall commissure. Suppose this is mitral wall. This is mitral. We are looking from the beneath side to our top. So it would feel like this. This is anterior cusp and this is posterior cusp of the mitral wall. So normally if cause is any other cause like radiation therapy age related, so it will affect the posterior cup. This one, है ना? There is calcification, fibrosis, and this is opening of the wall. So in case of rheumatic mitral stenosis, the calcification and the damage is in the wall commissure. What is wall commissure? This is anterior wall, posterior wall, and this is commissure toward the inside. Na? So here is the damage. So this will what you see on pathology. Now there is clinical presentation. How the patient will present to you in clinic. Normally now blood is not coming from left atrium into the left ventricle. So there is less blood in left ventricle and less blood will go into the body. So if it means the cardiac output is low, and when there is cardiac output, when there is low cardiac output, it causes dyspnea and fatigue. Why? Because the body is receiving less blood, less oxygen, so it will go into the anaerobic respiration, so it will produce more acid, and this acid will cause fatigue to the patient as well as dyspnea. Now blood is accumulating here in left atrium. The blood that is coming from lung into the left atrium is also not coming. Why? Because there is more pressure. So there would be increased pulmonary capillary wedge pressure in the lungs. The capillaries in the lungs having more pressure because blood is not coming into the left atrium. So it would cause orthopnea. Orthopnea means patient is feel dyspnea at night. When it's in the supine position is lying, he will feel dyspnea. Paroxysmal nocturnal dyspnea and hemoptysis. Why hemoptysis? Hemoptysis mean the blood in when you cough there would be blood. Why? Suppose this is pulmonary capillary, and now the pressure is so much that blood came from here into the alveoli, है ना? Into the alveoli. This would cause hemoptysis. And now there is increased pressure in the lungs. So right ventricle pump blood into the lungs, and now there is increased pressure in lung. So right ventricle is also failed because it's not pumping normally. So when there is right side heart failure due to the left side heart failure, remember the most common cause of right side heart failure is left side heart failure. So central venous pressure is increased. When central venous pressure is increased, when the blood that normally came into the vena cava is not coming. Why? Because there is accumulation of the blood, because blood is not going into the lungs. So here would be, it would cause central venous pressure is more. This is cause jugular venous distension, hepatomegaly, and left extremity edema. All these are symptoms. First symptom would appear due to the cardiac output or less, dyspnea, fatigue. Then if pulmonary capillary wedge pressure is increased, it would cause orthopnea, proximal nocturnal dyspnea, hemoptysis, and when there is central venous pressure is increased, it would cause jugular venous distension, hepatomegaly, and left extremity edema. Now suppose if a patient is female and he is pregnant. And now we know in pregnancy the blood volume is increased. Why? Because there is no more requirement of the blood. Why? Because there is baby as well. So more blood is required. When blood volume is increased, it will cause precipitant of the symptom. Here suppose patient is pregnant, it would have more blood. So more blood is not coming into the left ventricle, and less blood is going into the body. So in pregnancy the symptoms are aggravated, mean precipitant, more symptom would appear in pregnancy. The other clinical presentation could be atrial fibrillation. Why? Because now more pressure in left atrium, it was called left atrial enlargement. So left atrium is enlarged, है ना, it is enlarged, and when there is enlargement of left atrium, obviously it will call atrial fibrillation. And he's saying increased risk of cardiothromboembolic risk, increase in cardiothromboembolic risk. Why? Because and now blood is not coming from left atrium into the left ventricle, and blood is accumulating here. When blood stop in any artery, any place, it will cause formation of thrombosis, है ना. So this may go into the any part, like if it go into the brain, it would cause stroke. If it go into the kidney, it would cause acute kidney injury, and it was suppose it go to the coronary artery, it would cause MI. Now physical examination. After clinical presentation, how will you diagnose physically? How will you examine the patient? The first is rumbling diastolic murmur. Mean when you put on your stethoscope and put on cardiac epics. Cardiac epics, remember it, cardiac epics. So you will hear a specific murmur during diastole, not during systole, and its nature is rumbling. Now the second physical examination is on stethoscope is S1. And what is S1? Normally when wall of mitral wall and tricuspid wall close, there is sound, है ना. This sound is S1, and when there is closure of pulmonary wall and aortic wall, the sound is S2. So he's saying that soft S1. Normally it's S1 is loud, but now it is soft. Why? Because wall are not completely closure. When there is no closure, there would be no sound. And why S2 is loud? Because suppose here is S2 is due to the, this one is pulmonary wall. Now there is more pressure in lungs, है ना. So backward pressure is also increased. It would cause these pulmonary wall to collapse more loudly. So more S2 is produced, it means there would be loud S2. And on ECG you will find left atrial enlargement as well as right ventricular hypertrophy. Why right ventricle is hypertrophed? Because there is more pressure in the lungs, and right ventricle try to compensate by increasing its muscle mass. So on ECG you will find left atrial enlargement as well as right ventricular hypertrophy. On chest X-ray you will find pulmonary edema. I'll attach the pictures of the normal X-ray as well as pulmonary edema on chest X-ray. So these are physical examination. The most important thing is rumbling, diastolic murmur, soft S1, S2, loud S2. On ECG, left atrial enlargement, right ventricular hypertrophy, and on chest X-ray you will find pulmonary edema. But there is no enlargement of left atrium, so you will not find that its apex heartbeat is displaced. No, it's on the normal place. And now how will you make diagnosis? Diagnosis is basically when you, on the basis of clinical presentation. Suppose patient present you with he's saying that I'll feel fatigue from the I'm feeling fatigue, dyspnea, or any of these symptoms. Your doubt will go toward any heart disease. So what you do the auscultation. On auscultation you find this. So it is based on normally clinical presentation, all these what we have studied, plus echocardiography. On echocardiography you will find elevated transmitral pressure. The pressure along the mitral wall is more. Here in left atrium it is more pressure, and left ventricle it is less pressure. So normally suppose it is 10 and now it is elevated, it is 20, and the difference is more. So first thing you will find this. The second is mitral wall changes. You will find calcification, you will find fibrosis, because this mitral wall is now thickened as well as calcified. So these changes you can also find. The third is narrowing of mitral wall orifice. Normally wall is supposed like this. It is now narrowed. It is like this one. It is narrowed. How narrowed? How much is narrowing? It is less than 1.5 centimeters square centimeter. Okay. You can also find left atrial enlargement here, as well as without left ventricular hypertrophy, because there is no blood volume overload or pressure on the left ventricle. So left ventricle is normal, but left atrium is enlarged, as well as right ventricular enlargement you can also find. So diagnosis is basically on the basis of echocardiography. It is the test of choice. So how will you manage the patient? It's very important. If there is asymptomatic patient or there is mild to moderate mitral stenosis, you will do nothing. You will just say him, please come to my clinic on regular basis, like on every month or every 6 month periodic clinical evaluation. Why? Because you're not going to do any intervention at here, because patient is not symptomatic, है ना, till now. And now if patient is symptomatic, it is having severe mitral stenosis or there is symptom appear, so what will you do? Either you manage the patient medically or surgically. Surgical management is definitive management, है ना. If you want that your patient will remain good for most of his life, then you do treat it surgically. The medical therapy is limited. But limited medical therapy is which one? Diuretics, because it is having pulmonary edema. So to counter this, you will give him diuretics like furosemide, and negative chronotrope like beta blockers, so that it heart rates reduce, as well as left ventricle has time to fill, है ना. If heart is beating slowly, so it will have more time to fill. As well as anticoagulation therapy. Here we have studied that there would be thromboembolic risk. So in order to prevent this one, we'll give it anticoagulation therapy. This is limited. Patient will not fully recover. To fully recover the patient, there is surgical treatment. Now it is of two types. Either it is procedural intervention or it is surgical wall replacement. Either you replace the wall, you will insert a new wall here. Either there is intervention like percutaneous balloon mitral chromisotomy. That is normally called as PBMC, percutaneous balloon mitral chromisotomy. So in this, what you do, it is an intervention in which you insert a catheter that go into the heart. Specifically, it go into the mitral valve. At this stage, the balloon is opened, and here you insert a new wall. So it is preferred over replacement. This intervention, procedural intervention like PBMC, is preferred over replacement. If you have two options, either replace the wall or either you can do this procedure, so you will have to prefer this one because it has less complication comparatively. And now the definite treatment, other one is surgical replacement. If there is complex mitral stenosis, the anatomy of the mitral wall is differed. Now your choice would be surgical valve replacement for complex wall anatomy.